The report on a new taxonomy of disease started as a way of thinking about how we bring the explosion of new science and molecular information brought to bear on the definitions of disease. Our committee was so inspired by what's possible today that we moved quickly from defining diseases to thinking about an entirely new way to think about linking basic science to the normal course of clinical care, so that not only do we bring basic science rapidly to the clinic to help patients, but the patient's clinical data can rapidly be brought back to the bench to ask basic questions about how can we improve outcomes. The vision that the new taxonomy precision medicine report brings for a basic researcher is that any basic researcher who has a hypothesis can access an information commons that will allow them to interrogate large numbers of patients so that they can ask and answer incredibly important questions, not in a very limited, discrete way, but in a way that allows for the power of large numbers, both the power of large numbers and real clinical information, so that questions that are extremely important in the prevention and treatment of disease can more rapidly be answered. We wanted in our report on precision medicine to bring real patient examples to describe the vision that we had about what's possible. And so we described patient one, who's a woman with breast cancer today. In 2011, it's possible for a woman with breast cancer to go to the clinic and to have her breast cancer defined in a molecular way so that the treating physician can put in front of that patient choices for therapy that are very precise and targeted to the molecular signature of her breast cancer. In addition, a breast cancer patient's family can access testing that will allow for them to understand better their personal risk of breast cancer or ovarian cancer in the future. That's a very different world than for patient two, a patient with type 2 diabetes. Unfortunately, although we know much more about diabetes today than we did 50 years ago, we're still using the most common medicine in the United States for diabetes that's more than 50 years old. And in fact, patients with type 2 diabetes, it's not possible to have a molecular test to look at their future course. Will they lose their vision? What's their risk of an amputation? So the vision of our committee is that patient two with type 2 diabetes could live in a world where they have a precise diagnosis, a potential for more precise therapy, and their family can understand their personal risk.